Welcome everybody to DeBakey CV Live, coming to you directly from Houston, Texas, Texas Medical Center, DeBakey, located at Houston Methodist Hospital. We are live in the studios here in Houston, and Dr. Ohtsuka is live from Tokyo, Japan. As you know, first Tuesday of each month, 5 p.m. Central Time, we come live from Houston, Texas to discuss atrial fibrillation. The topic tonight is minimally invasive AFib surgery in Japan. I think this will be of interest to many people. We know a little bit about what we do in this country, but it's nice to know what other people are doing as well. AFib is a disease of all humans. There's AFib in Asia, Africa, Europe, North America, South America, and if there were any people in Antarctica, there'd be AFib in Antarctica too, I believe. The story is a little bit like this. I'm going to give an abbreviated version of how we got to where we are today, with me coming from Houston, Texas, and Dr. Ohtsuka coming from Tokyo, Japan. First of all, this presentation is brought to us through DeBakey CV Live, the brainchild of our fearless leader, Dr. Alan Lumsden. And it's been a vehicle for us, particularly during COVID, to get the word out to patients about what we are doing and what possibilities there are for different treatments of medical diseases. This is for AFib. What's the story? Well, the story goes back to Cincinnati, Ohio, many years ago, probably 25 years ago, when Dr. Morita from Tokyo was visiting, and I was introduced to him. He then made introductions to the University of Tokyo, and we developed a relationship between the University of Tokyo and Cincinnati, and then when I moved to Ohio State, also Ohio State, where we shared fellows from University of Tokyo. Dr. Ohtsuka was one of our fellows in Cincinnati. My mentor was there at the time, Dr. Flagey. But really, Junji Morita is really the one who started this. That was a very good collaboration, which we carried on for probably more than 10 years. Then go forward many years to an engineer who I had been working with on some different projects. And this particular engineer had an idea that maybe we could isolate the pulmonary veins with bipolar radio frequency. The engineer's name was Mike Hooven. We met in Cincinnati. He told me about his idea. We made the clamps, and that company, Enable Medical, spun off another company to cure problems in the atrium called AtriCure. I used that technology and helped the company get started on the clinical side and engineering side. And some years after we started using the product, I suggested to Dr. Ohtsuka that he might look into it. Why do I say that? Well, the procedure that we're going to talk about, I think, is a very simple procedure. It's a procedure to treat atrial fibrillation. It's a one and done procedure as opposed to catheter ablation and medications for life and blood thinners for life. So it's a very elegant solution. But it is simple, but it's not easy to perform. Sort of like basketball. Basketball is very easy. Shoot the ball wherever you want, anywhere on the court, just put it through the hoop and you get 2 or 3 points. So it's pretty simple, but it doesn't mean it's easy. The reason that I presented what we were working on to Dr. Ohtsuka was for 2 reasons. One, he's a very smart guy, one of the smartest surgeons I know, and he's got really good hand-eye coordination. And I think that's what it takes to do some of the things that he'll share with you today. He's a very modest man. He won't tell you this, but I can tell you that's what it takes to do this sort of procedure. Dr. Ohtsuka started doing this procedure several years ago and turned it into really a national program. He's widely acclaimed as the AFib surgeon in Japan now, and he's the key to minimally invasive AFib surgery in Japan. He uses devices that are made in Cincinnati from the AtriCure company, and we'll talk a little bit about that. So that's a little bit of the synopsis of the story. Toshi and I have known each other probably now for over 20 years. We've had a very good collaboration. I always enjoy traveling to Japan. It's my favorite place to not only teach, but also to vacation. Wonderful country to vacation in. I've learned a lot about the Japanese, and some of it I try to emulate back at my own home. So with that short introduction, Toshi, I know it's early in the morning. Thank you for joining us live from Tokyo. We made one little error in the place where you're practicing, so if you correct us, I would appreciate that. And welcome to DeBakey CV Live.
Thank you very much. Thank you, Randy, for having me here. And hello, everybody. I'm Toshiya Ohtsuka. I'm now speaking from Tokyo, my hospital, NewHeart Watanabe International Institute. So I'd like to share the slides. Is it okay?
Yes, and while you bring that up, there is a little bit of housework I have to do. We are inviting questions. The questions can be for anything about AFib surgery in Japan, anything about AFib. They can be engineering questions. And there are two ways to send us a question. You can take your phone and go 37607, and in the text box put DeBakey, and that's on your screen. Or if you're on an internet, on a computer, not internet. If you're on the computer, go to pollev.com, enter DeBakey as it's shown on the screen, and respond to the activity. And on both of these, you can send us questions, and we will answer all the questions live in this next 40 minutes or so. So again, you can text from your phone or from your computer, pollev.com, enter DeBakey from your phone, 37607, and then text the word DeBakey. Oh, sorry, Toshi, back to you.
Okay, thank you, Randy. I'd like to talk a little bit about my procedure and experience in Japan. And also, I'd like to discuss many issues with Dr. Wolf. Okay, this is my COI. So I moved to the current hospital, which is NewHeart Watanabe International Institute, which is one of the best heart surgery institutes in Japan. So I made a center of Wolf-Ohtsuka procedure 2 years ago, and I'm now intensively performing my procedure here. So this is my patients, where did they come from? So regional patient number. So actually the patients come from nationwide, from North Island to South Island and Okinawa. And my institute is international, so we can take care of the patients from other countries. So actually, I treated some patients from other countries. So if you are interested in my procedure, please contact me through my email. So this is a pie chart which shows why my procedure was chosen. So a third of the patients come from cardiologists. Actually, some cardiologists ignored my procedure. However, some of them very highly evaluate my procedures and send many patients to me. And secondly, neurologists. Neurologists are taking care of patients who actually has had cardiogenic strokes once or twice. And of course, they are at great risk of stroke again. And also, they tend to be very old. They also has high risk of blood thinners. So they are very good candidate of my procedures. So a few national neurological centers choose me and send many patients to me. So those patients are increasing in number. Thirdly, nephrologists choose my procedure. Nephrologists are taking care of patients who are on hemodialysis. Actually, hemodialysis cases tend to suffer atrial fibrillation rather than others. So they have to protect their brains, but Coumadin is actually contraindicated for those patients. So they are actually in dilemma. So those patients on hemodialysis is best candidate for my procedures. So the nephrologist is sending many patients to me now. So the patients are increasing. Lastly, patient preferences is greatest power of choice, of course. The patients are given recommendations by their doctors, cardiologists, EPs, saying you have the chance of cure by only catheter ablations or Watchman. Of course, some of them obey their recommendations, but others are not so faithful and look for something else using the internet or books or something like that. And they finally choose my procedure and come to my office. Probably many of the Randy's patients come to his office through the same course, I think.
Well, you're right. You're right, Toshi. It's interesting if we look at that pie chart here in the United States. It's similar, although the cardiology portion would be a little bit smaller, and the patient preference would be a little bit larger, and the nephrologist portion would be a little bit smaller. But one of the patients I operated on yesterday was on a blood thinner, and they had a bleed in their brain, not an ischemic stroke, but the other end bleeding, and had a very significant stroke, and that's why they came for the mini maze. But yeah, it's very interesting. It's similar, a little bit different proportions, but very useful.
Actually, the patient preference part is becoming larger and larger. And for this purpose, I'm sending a lot of information using, for example, my book, which I published last year. Now, almost 10,000 copies are sold only last year. Also, I update my homepage, which is almost 10 years old. So the last year alone, I got 7,000 visits, and that is working very well. So you have, Randy has his nice homepage, and that's working. Also, I'm now using the SNS like Twitter or Facebook. Actually, I'm sending my message almost every day about my procedure or my activities. So I write sometimes in English. So if you're interested in my procedure and my activities, please follow me. And also, I'm sometimes on TV program. TV is old-fashioned, old media, but still working. So many old patients come to see me because I'm on the TV and say something about my procedure. So probably Randy is doing the same thing, I guess.
Well, similar, but I don't have a book. You're very good at writing books. This is not Dr. Ohtsuka's first book. And a little side note, Dr. Ohtsuka is also an excellent illustrator. He illustrates his own books.
Yeah, that's right. This book is a patient-oriented book. So I use very easy vocabularies and explain my procedure and AFib very nicely to the patients. So you should write this kind of book.
Maybe we'll just translate your book.
Okay, I can help. Okay, the next slide is about my procedural algorithm. So I started this operation in 2008, I guess October, and already I treated 1,900 cases. Probably in the middle of this year, I will reach 2,000. So the patients, there are many types of patients. So first I of course consider the operability, and we examine many things, and 1% of the patient is contraindicated because the chest is inaccessible. For example, this kind of chest X-ray shows, well, I cannot do this operation, but only 1%. So the rest of 99% of the patients can be treated. And 30%, roughly 30% is paroxysm, and 90% is persistent, long-standing persistent cases. How about your patients?
Well, I think it's very similar. Paroxysmal is probably about a third, and the other 2/3. I do some patients who've had previous heart surgery, but they have to be evaluated very carefully. Some patients after coronary bypass and some other procedures, but maybe only 30 or 40 of those.
Okay, almost similar, I guess. And then I consider what should be done. Of course, paroxysmal case and what should be treated with ablation and appendectomy, which I called Wolf-Ohtsuka procedure 1, W1. And chronic cases, I use cardioversion at the time of operation on the operating table. After the patients are put to sleep, I administer cardioversion to the patients and see what happens. So if the sinus rate recovers beautifully, I mean, if the cardioversion has good response, the patients go to procedure 1, W1. And if the response is not so good, and sinus rhythm does not appear, and the patient is rate controlled very well, the patients go to procedure 2, W2, which is standalone appendectomy, meaning appendectomy alone. So the percentage of W1 is 97%, and W2 is 3% only. So probably the flow chart is a little different from Randy's, but 97% versus 3% is almost similar to yours. So which means we are doing the same things.
Yeah, I think you mentioned to me that in the chronic AFib, you are putting those patients on an antiarrhythmic pre-op.
That's right. And yeah, of course, I consider what type of drugs they are taking. So if they are taking many drugs, which means the patients are not rate controlled well. So in that case, the patients go to procedure 1. Yeah. But the patients, in some patients are naturally rate controlled, right, without no medication at all. So in that case, and if that cardioversion result is poor, they go to appendectomy only. So there are many really limited cases, I think. So probably we are treating the same way. Okay, the next slide is clinical path for my procedure, almost similar to yours, so I don't need to explain a lot. My procedure started 3 months or 4 months before surgery. This is actually a waiting time before that patient can receive my operation, but I use that waiting time very effectively. For example, I performed upstream treatment, such as treatment of obesity, sleep apnea, or even stress. So that is very effective to improve our procedure. So very interesting enough, my patients, 70% of my patients suffer from sleep apnea, and half of them, they're very, very sick. I mean, needs CPAP or some treatments. So the sleep apnea has much to do with the occurrence of atrial fibrillation. So probably same in the United States.
Similar.
Yes. And the patients are admitted to hospital 2 days before the operation. And the patient's down, the day 1 or 2, the chest tube is out, and the day 3, the W2 cases go home. And the W1 case go home the day 5. And as far as blood thinners is concerned, simply put, the patient can get out of blood thinners just after surgery, except the cases who had very bad heart function. For example, the cases with cardiomyopathy. Cardiomyopathy is a disease, heart disease, which is progressive. The heart function is getting worse and worse. In those cases, of course, the stroke risk is reduced with the appendage resection, but still needs blood thinners. So those cases should continue the blood thinners. But otherwise, the patients can get out of blood thinners just after surgery. It's almost same to you, right?
Yeah, sometimes if a patient has had a stroke, I will continue the blood thinner for maybe 30 days, but I don't have any hard data to say that's the right thing to do. But some patients are a little concerned if they've not a hemorrhagic stroke, but an ischemic stroke. Otherwise, about the same. We're not allowed to admit the patients before the surgery, but the other stuff has to do with more the American system versus the Japanese system. But otherwise, it's about the same. Let me interrupt just again, and Mr. and Miss Producer, if we show the screen on the to call in for questions. If you have a phone, if you're on your phone, simply go to 37607, text DeBakey. If you're watching us from computer, go to pollev.com, enter DeBakey. Your questions can be about your own history of AFib, what you're struggling with. They can be about your experience with AFib. They can be questions about differences in how we do things. Any questions are okay. Okay, Toshi, go ahead back with the next slide.
Okay, I would like to say something about Amio down protocol. I think it's almost similar to yours. And Amio is very effective, but it's difficult to use and to have weaning process, but it's very effective. Okay, the next slide. My patient demographics. The case number is almost 2,000, and the male is the majority of my procedure. The mean age is 74 years, and the youngest 24, the oldest 104. And the wave type is paroxysm 30%, and persistent or long-standing persistent is almost 70%. And CHADS-BASC score is a risk score of a cardiogenic scope, and they're relatively higher, I think, than catheter ablation patients. The hazard score, also this is a risk score of blood thinners, is relatively higher than catheter ablation population. So probably that's similar to yours, yes.
Well,
the patients getting older.
Yeah, I don't pay much attention to that because we're doing the procedure for a different reason. I do think the left atrial size is very important, and we've gone to documenting what the left atrial size is on the CT scan pre-op because it's more accurate. And if they're around 100 milliliters in the left atrium, that's upper limit of normal. Once it's over 200 milliliters, that's a pretty big left atrium. And as Jim Cox has pointed out many years ago, there is a correlation with the size of the left atrium and the success of the treatment.
Even if the left atrium is larger than
right.
5 centimeters, if the cardioversion test is okay, the patients can show the sinus rhythm, I would do the operation.
Yeah, that's a very good point. And since you mentioned that to me, I'm doing more of that. It's a very good point. Can we work in a question right now? We're going to start taking some questions, so you can again reach us by the internet or the text. First question is, what is the rate of stroke long-term with WO or Wolf mini-maze and no anticoagulant versus just anticoagulants? Could you discuss research being done on the left atrial appendage? Really two different questions. I'll let you take the first part of that. And the question is stroke rate if you've closed the appendage. And I know you're going to show us how you do that.
I can show the slides afterward. So I have slides, so I can show you later. Okay, that's okay?
Yeah, and it also, next question is, Dr. Toshi decision chart shows an appendectomy. Discuss the difference with the Wolf procedure. Well, really, we're both closing the appendage. You're doing it with a stapler. I used to do it with a stapler, but now I use the clip because it's maybe a little bit easier, maybe a little bit faster, but I think either way is equivalent. What do you think?
Yes. Yeah, that's the same answer. Yes.
You'll show some of that, I guess.
Yeah, I'm frequently asked which is better or kind of things, but either is fine if you have good hands. So the result is.
That's right. It's not.
So, clip is a little expensive, right? So that's a little different.
Clip is more expensive, but as you point out, it's not so much the gun; it's who's firing the gun that makes the difference.
Actually, either can produce the same result. That's a very good.
Yeah.
Good point, I think. Okay.
Go ahead.
Can I continue?
Please.
Okay. All right. If you retrospectively see the history of my procedure, I started with your procedure, mini-maze procedure, assisted by Dr. Taketani, who used to be with you the year before, I guess. And he assisted me 3 or 4 cases, and I copied your procedure in the beginning, maybe 5 or 6 cases. Actually, it started October 21st, 2008. And this slide photo is exactly the first case of mine. And probably the same wounds, same approach as yours with mini-maze. And I did several cases, and I found that probably I can do this using my endoscopic technique. And so I made a mini-maze procedure a little more endoscopic. And finally, I'm not doing totally endoscopically, and the patients put on a supine position. So that saved the time of the procedure. So now, actually, W1 can be completed in 1 hour plus. And if the W2 is chosen, the procedure is only 15 minutes. So the wounds for endoscopic procedure is like this. So maybe cosmetically good, and patients are pleased with my procedure because of these cosmetic reasons. And I'd like to explain a little bit about the rhythm cure part of my procedure. So I use technology similar, the same one as the Randy used. As Randy mentioned, I use stapler and loop rather than clip. I use clip, of course, but mainly I use stapler and loop because for a couple of reasons. But the either is okay, and either produce the same result. So you should not care about which and the same result if the patient's skill is good. And this is my ablation part strategies. So probably very similar to Randy's, because I learned the technique from Randy. So if there is a unique point in my procedure, which is en bloc left pulmonary vein isolation technique, this is my cup of tea technique. I started 5 or 6 years ago. And as Randy mentioned, the epicardial part, usually covered with fat tissue, is a very important part, which is responsible for atrial fibrillation, because autonomic nerves are rich there. So if I exclude that part widely, as a result of a rhythm cure should be better. So the en bloc technique allows me to exclude the fat tissue in which epicardial nerves are there, excluded as widely as possible. So I can show you this technique really with very short video. This is appendage, and this is a clamp. I clamp medial to the appendage, which means the fat tissue surrounding the appendage, which is containing a lot of autonomic nerves, plexus, can be excluded using this one clamp, single clamp technique. So after the clamp, the appendage is motionless because conduction is lost. You can see the scar, and of course I removed the appendage after that. So I think this technique improved the result of my ablation because of this technique, I guess. And the result was published 3 years ago in the journal, and I presented in the STS meeting. So probably Randy's method and my method is very similar, because I think the epicardial part exclusion treatment is extremely important to treat the atrial fibrillation. Probably Randy agrees with this point, right?
I do agree with it, and what I do mention to patients is I have, and you have, a fundamentally different approach to AFib. And with catheter ablation, the focus is on burning muscle, burn the inside of the heart. Our focus is to go where the AFib starts, on the outside of the heart, in the nerves.
That's right.
And because I think most AFib starts as vagal AFib in lone AFib, people that only have AFib. So you should be on the outside of the heart. Now I have adopted your method of placing the clamp medial to the appendage. Is very nice because it dramatically increases the area of the isolated part of the heart. The other thing that your technique and the technique with the clamp is good about, it doesn't destroy the function of the left atrium. It's just making a line like a pencil. So the function of the left atrium remains intact. So yeah, I think these are incredibly important points, and your publication was fantastic.
Thank you very much. Yes, you're right that you mentioned the atrial fibrillation is a nerve disease, not muscular disease. That's the greatest point, I think. I love that word. I'm using that word frequently. Okay, this is my results. I know using the standard FollowUp protocol, so I do not use a link. But if you see my result, sinus rhythm without medication in 2 years, paroxysmal case 93%, and persistent case 86%, and long-standing persistent case shorter than 5 years 70%, and long-standing persistent case longer than 5 years 52%. That is, I think, it's a very good result. And probably some questions come: what would you do? Would you do if the patient recur after your surgery? So answer is I use the hybrid technique, hybrid ablation technique. I have a very nice EP physicians in my team. So the patient needs some touch-up ablation. I send the patient to him. He take care of the patient using touch-up ablation. So the sinus rhythm rate becomes much higher using the hybrid approach, hybrid technique. So you were talking about the hybrid approach, the previous live talk.
Yeah,
So,
it's the same thing. We do the same thing. I have a electrophysiologist here, Dr. Fahad. He tells me that if he has to go on a patient that's had the mini maze, the veins are isolated, the appendage is closed, he can focus on one area. He says it's much easier than doing catheter ablation. And Toshi, our results are almost 100% patients back in rhythm. So it's it's amazing adjuvant to patients who've been out of rhythm for 5 years. We can still get them back in rhythm.
that's right. It's a miracle. So
Yeah.
I think, not only ablation, but also appendage, we can do two things at the same time.
Right.
So that's beauty, the strength of a procedure over catheter.
We're getting a little bit, I want to get a few more questions in, so I hope you don't mind me interrupting you.
No, it's okay.
Here's the first question, and you can answer these. Does it make it more difficult or take more time for the procedure if you have a pacemaker?
No, I don't care about the pacemaker
That's
placement.
right. And is the pacemaker turned off? No, you don't have to turn it off.
No.
Here's
That's
another.
a very useful device
Yeah,
for my procedure.
It's kind of nice to have it. I still put a wire on the right side of the heart so I can pace externally until they go home. Here's another question. What happens to your heart if AFib is left untreated or your EP says to remain on medications as long as possible?
Well, that depends on rate control situation. If the heart rate is still very rapid or very slow, the patient's heart function will be damaged in time.
That's right.
But rate control, probably you can live until you can live.
Well,
So
if they recommend continued medications, there's still an increased stroke risk every year from taking the blood thinner, right? And if
That's right.
So
Yes.
that's
So
one
depends
difference.
on the patient age and patient's lifestyle and patient's maybe job to do. So depends on the patient, I guess. I always ask what your hobby, what your job to do, what's your lifestyle like this. So all the answers are considered to make judgment of what should be done. I think
That's true.
I
There's also peace of mind. People would like to stop worrying about their heart every day and worry about something else. So for many patients, they tell me, they want some peace of mind.
actually, yes, that's right. And also, atrial fibrillation patients tend to be very sensitive, right?
Yeah, of course.
Yeah,
Now,
it's very
here's a-
sensitive patients. There are a lot of very sensitive patients, so they worry about the future. And actually, our procedure can take care of the quality of life of the patients in the future.
Here's
That's
another
great.
another question for you. Can these procedures, the minimally invasive AFib procedure, WO, mini maze, be done for persistent/chronic AFib if the patient has severe COPD and stage 3 chronic kidney disease?
I have done maybe not so small number of patients, many patients with COPD, but you need a good anesthetist who can control the lung collapse very well. But I can take care of that patients with.
I agree. Because interestingly, people with COPD really do pretty well with this procedure. That's not the problem. Mm-hmm. You're right. Mm-hmm. Now here's another question for you, Dr. Ohtsuka. What do you mean when you use the term atrial thin? I'm not sure if that came through right. I don't understand that. I'm not sure what that is.
What's that?
I can't read it. Let's go to a different one. Is the heart prone to more damage if you get AFib at age 50 versus age 75?
Well, I don't know. 85 years old, 75 years old, that's a big difference. Actually, I have treated a lot of patients in 80s or even 90s. Mm-hmm. So, but also, the age is not so important. Of course, there are frail patients in 60s, right? So yeah. I always see the patients, age may be important, but more importantly, I see the patient's kind of energy or, entire situations, conditions. If the patients, I ask many questions about the activities of the patients. If the patient, last week I saw the patient in 90. He is walking every day for 2 miles or so, and that he's very healthy, and he wanted to have my procedure. As I said, okay, you are right. You are my best candidate, right? So the age is not so.
The question may also mean in English that is it worse if you get AFib at a younger age?
Well, I always consider the risk of stroke. So the older, the worse in terms of the risk of stroke. So if you're old, you are very good candidate for my procedure because appendage is treated. So I always say so.
Now I also think it's risky when you're young, because if you have AFib when you're younger and it's not treated, I think there is some evidence that over a long period of time there is a higher risk of heart failure, and there's also, some people say, higher risk of brain damage to small vessels, yes, such as Alzheimer's type symptoms.
Yeah, young patients have the reason, and older patients have the other
different reason. Let's another question for you. Is there an absolute contraindication for the WO, 1 or 2? I
guess I showed the very good slide showing the pneumothorax case. And if the chest cavity is inaccessible, that is contraindicated. And otherwise, I can do almost all the cases. And also, well, probably there was the cases in which I could do only appendage part, but not ablation part, because of very thick scars in the thorax. Yeah. So that case was treated using hybrid approach, hybrid catheter approaches. So I did appendage part, and then the patient was sent to the catheter ablations for rhythm.
Another question is, does a patient always need a cardioversion after the procedure?
I apply if the, that is very good questions. I use the cardioversions maybe 1 month or 2 months after surgery if the atrial fibrillation occur, and see what happens. Probably still on Amio and the cardioversion works one month after surgery. That is my protocol. Probably the same things done by Randy, I guess.
It's the same. If they have AFib post-op, I usually wait 1 month with antiarrhythmics, do cardioversion, and most of the time that takes care of it. If not, then we go to the more of a hybrid approach, wait 6 months.
Yes.
Here's another question for you. You're getting a lot of questions, Toshi.
Thank you.
I am a junior surgeon, integrated PGY3, interested in learning this procedure. Do you have any fellowship or clinical attachment program in your institution in Japan?
Very difficult questions. So anyway, please contact me using my email.
Okay.
That's all I can say now.
Is there a minimal AFib burden below which you would not do the procedure?
What's that again?
So is there,
repeat it again.
I guess what they're trying to say is, how much AFib does a patient have to have for you to say we need to proceed?
What's your decision?
Well, see, it's complicated, and I think yours probably is too. Some patients say, I only get AFib once a month or once every 2 months, but when I get it, it's terrible. I'm afraid to travel. I'm afraid to get on an airplane. I don't want to take medications. I don't want to take blood thinners. Some patients are fairly well controlled on medications and blood thinners, but if you take them off the medications, they'll probably have more AFib. And they just say, look, I want a one and done. I want to get off these medicines. I want my life back. And a lot of patients are pretty smart, because I found out if you stop all the medications, which we do after the procedure, they feel a lot better. You feel a lot better if you're not taking 100 milligrams of beta blocker every day.
That's right.
So it's not an easy question.
If the patient is taking some drugs, antiarrhythmic agents, I think it's a good candidate for my procedure. Also, the patient has suffered some kind of side effects of blood thinners, like bleeding or subacute bruises all over the skin. That could be a good candidate for my procedure. So how long AFib was, it's not so important for me to make decisions, I guess, as you said.
I'm going to answer one more question, then I want you to get back to the rest of your slides. Let's use this model right here. If we can zoom, or you're on, okay, thank you, Mr. Producer, on the model. This is a model of the heart. The question is, what's the difference between AFib and A-flutter? In AFib, and by the way, this is the right atrial appendage and left atrial appendage. This is the right and this is the left atrial appendage. This is what Toshi showed that he removes right here with the stapler. In atrial flutter, the top two chambers are beating faster than the lower two chambers. Both chambers are beating, but usually the top two chambers are beating twice as fast or more than the lower two chambers. In atrial fibrillation, the top two chambers are not beating, they're just shaking. So AFib, they're shaking. Of course, these are still beating, but erratically. In atrial flutter, the top two chambers are beating too fast, and the lower chambers usually slower. So with that, I want you to go back to your slides, and we'll give you a few more minutes without questions, but then we'll take some more questions. So if you have questions, we'll still take them, and while Toshi is going ahead with his next slides.
Okay, I'd like to briefly show the presentation slide about appendage part, okay? This is too much. Okay, I would like to show this one. My appendage stapler resection should produce high quality of the results. The appendage right here can be flattened perfectly, the left appendage management should have such best quality of flattening, because the patient's needs for the patients, the left appendage management can become last resort. The patients, most of the patients who need appendage management is desperate for something else. So we should not compromise the quality of the appendage management. So the surgeons who can do that completeness are qualified to do left appendage management. I strongly believe so. So don't compromise, don't excuse in left appendage management. I would say so. So the beauty about procedure, clip or stapler, either is fine, but the strength of a procedure is we can close any size or any shape of appendage. I can cut such a very large appendage in 2 minutes. Shape, I don't care about the shape. So the beauty of my procedure, our procedure, is this. So, but Watchman cannot close big one or strange shape of the appendage.
Could you repeat that? You're talking about the Watchman, right? You said the Watchman, right?
Watchman cannot close the big one, right?
Yeah.
They have the limitation of the size and shape.
Right.
But we don't, right?
Right.
That's the beauty of our procedure.
Yeah.
The big one has a big risk of stroke, right? Because that can form the big clot in the appendage.
Yeah.
Crystal clear. So I answered that question by somebody, the results of my appendage closure. I published 3 years ago in Heart Rhythm Journal. So this is appendage alone, appendage resection alone was performed, and see what happens in 4 years, the midterm result, follow-up result of my procedure. And 201 cases was subjects of the study, and they're old patients, and mostly the long-standing persistent cases. And they are taking preoperative anticoagulation. Maybe 93% of the patients are taking anticoagulation. And they have almost a quarter of the patients had major bleeding events, such as intracranial bleeding or GI tract bleeding and others. So GI tract bleeding comes from mainly colon, like polyp or diverticum. So that is very common disease which can bleed using the anticoagulation. And see the procedure time. Now the average time was 28 minutes. Now I can finish it in 15 minutes from skin to skin. And of course, the safety is perfect, no blood transfusions. And the result is amazing, I guess. And follow-up period is 4 years, and anticoagulation was off in 98% of the patients. The question is, what happened to 2%? So 2% of the patients had cardiomyopathy, who had bad heart function. That was the reason why the 2% of the patients continued. But very amazing enough, the stroke which has no clinical impact, happened only 2 cases. And this is a very important number, 0.25 events per 100 patient years. Probably you don't know about that. The smaller, the better. Smaller, the better. So if you see Watchman's results or Kumadan's results, 2.3 or 2.6 events per 100 patient years, which means our procedure is 1/10 of the corresponding data of Watchman or warfarin or Coumadin. So 10 times stronger than other methods, I think. Well, we cannot do the simple comparison between our procedure or Watchman. That study is not available now, but I strongly believe that our prevention power is far much better than Watchman. Probably Randy agrees with this, but you cannot say so in the United States, right?
Yeah, that's a great paper, and I think Watchman is even higher than that. But yes, there's no comparison really.
Yes, but our impression is, our procedure is best, I guess. And also, somebody says 4 years is not enough. So I'm doing 10-year follow-up study using brain MRI. So brain MRI can detect very small stroke lesions due to microembolism. So I studied my cases who is 10 years over after my appendectomy alone. So I got the 31 cases, and the mean age is 82, very, very old patients. And they were, before surgery, they were taking Coumadin because it's 10 years ago, and very high risk of stroke and high risk of blood thinners. They all got out of blood thinners, and 10 years passed, and I did brain MRI and found that nothing. There was no stroke or new spots on brain MRI suspected of cardiogenic thrombembolism. It's amazing. Mm-hmm. And of course, 2 cases passed away because of chronic renal failure and cancer, but the rest of them are doing very fine. I saw all of them at my patient clinic. So this is amazing results. I have to publish it in the future. Probably Randy have seen that result before? Probably.
No, I haven't, but I'm not surprised. We haven't done that study. It's a great study. I'm not surprised. I really think that what you do pretty much eliminates thrombogenic stroke from AFib. And it as you say, a long time ago, AFib is not just a heart disease, it's a brain disease too. And
yes,
by doing what you do, you eliminate the brain disease.
That's right. So MRI can detect a very small one. So that's the beauty of this study. But somebody says, well, maybe microemboli come from the heart, like that. But I can say, well, maybe not because of this study.
Yeah.
I think. Okay. So this is why my procedure or your procedure, appendage closure, is more powerful than Watchman. There are 5 reasons. Can close more appendage safely and swiftly, and provides perfect quality, no gaps, no stumps, no indicated defects behind, and also more protective, as shown in my slides, and also helps cure rhythm. So I didn't mention a lot, but the appendage is arrhythmogenic, AFibgenic. It can cause atrial fibrillation. It also can cause atrial flutter. I didn't mention that, but I did 5 or 6 cases in which the appendage was a trigger of flutter.
Yeah. So
I did just only removal of the appendage, so the flutter gone, just like that. Mm-hmm. So that is the appendage resection can cure the reason. So also there is a bonus effects, which is hypertension control. So this is a very important paper with me as a co-author. And very surprisingly enough, hypertensive patients, our procedure or other epicardial appendage exclusion technique can decrease blood pressure, particularly in systolic blood pressure. So this is amazing effects, phenomenon. Mm-hmm. And actually, I studied my patients, and yes, really this happens. So systolic and also diastolic blood pressure was decreased significantly. So which means, clinically means that the AFib patients tend to have hypertension, right? So they are taking 1, 2, even 3 kinds of drugs of antihypertensions. So miraculously, the patients with hypertension can get out of not only drugs of blood thinners or antiarrhythmic agent, but also drugs of antihypertension. So that's miraculous. And actually, 2 months ago, I did operation for the patients who are taking 5 kinds of drugs, including the blood thinners and beta blocker and 3 kinds of hypertension drugs. Now all gone. So that is a kind of miraculous phenomenon. But Watchman cannot do this.
No.
And I think this is actually in the future will help the patients who have atrial fibrillation or not. So regardless of atrial fibrillation existence, probably this surgery, the appendage management closure, maybe become a new treatment, surgical treatment of hypertension. That is very important. This is very interesting part of my procedure. Also, the researcher group found that the appendage resection can improve homeostasis of the patients. For example, the improvement in metabolism of glucose or lipid, which means that the appendage resection maybe cure the diabetes or some lipidemia. I don't know how this works, but maybe the appendage has some potential power to cure some diabetes, diabetes or lipidemia.
So we're about the top of the hour. We got a couple more questions I want to get to. How many more slides do you have?
Oh, okay. I'm not doing the research. Yeah, not only research but also education project. I'm making satellite centers of my procedure. So now it's a project has just started. So I need your help, right? Okay. Take questions.
Oh, I like that last one. Okay, this is interesting, and we'll take these pretty quickly because we're at the top of the hour, but I decided to let it run over a little bit because they're important questions. And number one, are electrophysiologists in Japan more likely to send patients for this procedure compared to the United States?
Looks like so. Probably I presented my papers, my procedure in the big scientific cardiologist meetings many times. And also I'm now invited to the cardiologist community to present my procedure. And a lot of cardiologists and even EP physicians are interested in my procedures. That's why they send their patients to me.
Yeah.
So you should present your procedure in the big cardiologist meeting, I guess, too.
So I think there are more EPs in Japan that refer than in the United States. Are there any technologies or procedures in Japan that are not in the United States or vice versa? Do we share these? Well, we do share them because most of the instruments that you use are made in Cincinnati, Ohio. But on the other hand, some of your techniques, such as going medial to the appendage, I learned from you. So I do think there's a pretty good sharing of information.
Exactly, yes. I'm now producing, I'm now in charge of producing a new device, new coagulator, which is whose energy is infrared light. So that I think that can be used in the future.
Okay.
So a complete device to coagulate heart wall. So I can share that with you in the future.
As you may know, Methodist Hospital here is one of the leaders in the world in transcranial Doppler observations. We noticed that during the mini-maze, there are no hits, no particles going to the brain, versus catheter ablation where it's 2,000 to 4,000 little somethings going to the brain during catheter ablation, 0 during the mini-maze. And this question says, are there any transcranial Doppler observations after the appendage removal? Well, not that I know of, but the transcranial Doppler is something you do, it's an episode. You're doing it one time. You're doing it while you're manipulating the heart. We don't usually do it afterwards. It's not a screening procedure, but when we closed the appendage, we did transcranial Doppler, and there were no hits.
Okay. I also go ahead.
While he's answering that question, run my little video here that's about 30 seconds, just so we can get a little thing of the clip in here versus the stapler. Are you on it? Okay, now go ahead and talk. Go ahead, Toshi.
Okay, my brain MRI result tells something about some micro embolism by my procedure. Nothing.
Yeah, that's true.
So I guess the result is perfect to tell about that things, I guess.
Yeah, that's true. And this is for those of you who are interested. You get the same results as a stapler. I generally am using the clip here in the United States, and it's like a big hair clip, and it closes the appendage off. So these appendages are not resected, but if you go back 6 weeks later, that appendage would just be a little scar. Well, we ran over the hour. We had lots of questions. We got to almost all of them, not quite. I want to thank you so much for all the research you've done on this topic, all the time you put into not only doing the procedure, but evolving the procedure and making it better, which I knew you would do. I knew you would do that. You're an excellent surgeon, very smart, great hands. There are a couple of people like you that I've trained, not very many. And I want to thank you for all that you've added to this field of atrial fibrillation and surgical treatment.
Thank you very much. I am grateful to you for giving me many opportunities and always encouraging me and inspiring me. Thank you, Randy.
You're welcome. If this presentation will be available after this is over, correct? And they'll be able to see it at DeBakey CV Live. YouTube. It'll be archived, so this can be viewed again. Thanks, everybody. Until next month, first Tuesday at 5 p.m. Stay healthy and wealthy during this pandemic. And thanks again to you and to Tokyo, Toshi.